Good morning and welcome to Plugged into Long Island on 102.3 WBAB and 106.1 BLI. I'm Al Levine and I'm with Dr. Kapoor, founder and past president of Integrated Medical Foundation, a not-for-profit organization dedicated to enhancing and promoting awareness of early detection for prostate cancer and providing resources to men and their families who are dealing with a prostate cancer diagnosis. The foundation provides information and guides them through the decision-making and treatment process. Dr. Deepak Kapoor is president of Advanced Urology Centers of New York, the largest urology group practice in the United States. AUCNY has 50 locations in 7 counties in the greater New York area. And we are talking today in particular about this topic due to the fact that Father's Day is coming up. So, Dr. Kapoor, thanks, first of all, for joining us this morning.
Well, thank you very much for having me again. It's always my pleasure to join you.
Great. How widespread is prostate cancer today?
Well, prostate cancer continues to be a significant problem in the United States. The American Cancer Society estimates that there'll be over 160,000 men diagnosed with prostate cancer this year. And the notion that prostate cancer is not a serious illness really should be put out of anybody's mind. Prostate cancer is the most commonly diagnosed solid tumor in men and is the second leading cause of cancer death in men. In fact, more than 26,000, almost 27,000 men are estimated to lose their lives to prostate cancer this year, and this is despite all the advances that we've made in treatment.
Why is that so widespread? Why is that such a large number, do you suppose?
Well, prostate cancer is a very interesting disease from the standpoint of its physiology. It used to be thought that prostate cancer was exclusively a disease of the elderly. And it is true that as you get older, the incidence of men that have prostate cancer increases rather substantially. But the simple fact is that prostate cancer can affect men of any age and of any race. Although that being said, there are certainly risk factors that are associated with the disease.
Sure. So it has been in the news lately, all of the screening and reasons for screening, et cetera. Can you tell us a little bit about that?
Yeah. Prostate cancer screening has unfortunately become a rather hot-button topic in discussions. There's an entity that makes recommendations regarding preventative services, and this entity is called the United States Preventive Services Task Force, or USPSTF. And their job is to review the available literature on subjects and issue recommendations as to whether or not certain services should be performed, and more importantly, under new healthcare regulations, whether Medicare will actually pay for those services. Mm-hmm. Now, as people may recall, there was a controversy that occurred in the earlier part of the decade, and in 2012, the USPSTF finalized a recommendation that said that no man under any circumstances, regardless of risk factors, should get a PSA done for screening purposes. And of course, the medical community was up in arms. The patient advocacy groups that spoke for men with prostate cancer and their families were aghast, appalled by that. And the community of physicians that were involved in the care of men with prostate cancer were also very, very deeply disturbed by this recommendation. Now, what we've seen since that time, unfortunately, is that a significantly fewer number of men have actually been screened for prostate cancer over the last 5 years. And as a consequence, the number of prostate cancers that we've been diagnosing has actually gone down rather substantially. Now, on the one hand, you could say that the USPSTF, their argument was that men who did not need to have treatment for prostate cancer were being overdiagnosed. Mm-hmm. And so if that were the case, you would anticipate that the pattern of disease that we would be detecting would be somewhat different than it is. Unfortunately, what we've seen is that for the first time, literally in decades, that we're seeing an increase in presentation of men with advanced disease and higher grade disease and disease that's more difficult to treat. So within the last 5 years, we've seen a marked shift toward more aggressive disease as men have responded to the recommendation to not be screened. And you say, well, why are they responding? Well, first of all, when it comes to healthcare decision making, and I don't mean to be sexist about this, so I apologize if it comes off that way, men are not necessarily the best stewards or guardians of their own bodies. Women do a much, much better job of being proactive about their healthcare and taking preventative action in terms of their own health. And
that's certainly been your experience.
Not only just my experience, but in fact, that has been clearly documented in the clinical literature.
Okay.
And in fact, if I'll tell you what my experience is. If I don't take my blood pressure and cholesterol,
someone's going to have to remind you.
Yeah, they don't get taken unless my wife puts them in front of me. So God bless her, she watches out for me.
Right.
So between my wife and my daughter, they're looking after my health care, and I think that the consumers of healthcare in most families are in fact women, and that's been studied. So when men are presented an option, when they say, oh, a government agency has said, I don't need to be checked for prostate cancer, which involves a blood test and a digital rectal examination, which is a little bit unpleasant, but blessedly brief for both the doctor and the patient.
Sure.
They will jump on that excuse and not
adds to their ammunition. Yeah.
Exactly. And so this provided them an excuse not to be tested.
Right.
And the biggest problem with this is that some of the greatest risk populations, remember we mentioned that there are specific risk populations for prostate cancer, and those risks are men with a family history of prostate cancer, particularly men of African American descent, and also some of our veterans that have been exposed to chemical toxins such as Agent Orange. But we've seen, in particular in the African American population, a very dramatic drop in the number of patients being screened, which is extremely troubling because this is the population that tends to present with the highest risk of disease. So what's happened is that for a period of over 30 years, we've had a nearly uninterrupted drop in the death rate for prostate cancer. And although we've not started to see the mortality climb yet, the estimates are that based on the pattern of disease that we've been diagnosing in the last 5 years, that death rate might increase. And obviously, we've been very, very disturbed by this.
Okay, so this is the time of year to really think about it, and it's extremely important to be screened for it.
There's no question about it. And as you mentioned, it's back in the news again because on April 11th, the USPSTF updated its recommendation on prostate cancer screening. And at that point in time, they made an acknowledgement that screening is of benefit in certain populations. And what they said was that in the population of men between age 55 and 69, that men should have a conversation with their doctors as to whether or not screening is right for them. And frankly, everybody is applauding the USPSTF for making the recommendation for that subset of the population. Unfortunately, the USPSTF, in the minds of those that take care of prostate cancer and in the minds of those that advocate for patients with prostate cancer, the prostate cancer advocacy groups, the USPSTF did not go far enough because they continue to say that men over 70 should not be checked for prostate cancer, which, again, we're very disturbed by. And the position that they took regarding the men with risk populations, those men that are African American or have a family history of disease or have had toxin exposure, that and they didn't really address the toxin exposure hardly at all, but they did talk about family history and men of African American descent. What they said is they acknowledged that there may be some benefit to screening in that population, but they didn't make any recommendation for it. So again, they're continuing to give men that out, that, oh, wait a minute, they only said for 55 to 69, but I'm only 53, I shouldn't be checked. Or, wait, I'm 72, I don't have to worry about prostate cancer anymore. And of course, nothing could be further from the truth.
So there's an overgeneralization here based on calendar age versus all these other factors that can play into the risk.
Precisely. Since when is one 70-year-old the same as another 70-year-old? Since
Right, of
when
course.
do we say that your access to care or the services that you get should solely be based on the year that you were born? I mean, this makes utterly no sense to anybody. You know,
Right.
we see so many patients because the population is aging, right? We're talking about the graying of America, and the segment of populations that of the population that's over age 70 continues to expand. You know, actuarial data shows that if you live to age 70, you'll probably live to age 80. And if you make it to age 80 without significant health problems, you have more than a 50% chance of living till age 90. The over 80 population, that demographic is expanding hugely.
Yeah.
And importantly, they're not moribund and bedridden. These are very, very active people. And what we found is that your greatest probability of dying of metastatic, of widespread prostate cancer is for men that are in their mid-70s to early 80s. So if we fail to diagnose these men when their disease is still organ confined, we may be consigning an entire block of men to an early demise that could have been prevented by a simple blood test. And so the urological community is united, as is the other specialties who care for men with prostate cancer. We're united in saying that, wait a minute, you know, it's great that you acknowledge for 55 to 69, but men over age 70, they don't fall off the earth just because they're age 70.
Right.
You know, they need to be afforded the opportunity to have a discussion with their doctors.
Sure.
And as we've discussed in the past, this becomes a major problem because under the new healthcare regulations that have been passed, it is possible for Medicare to deny coverage to men for this vital life-saving testing based on this grade D recommendation, which is why it's so important for us to continue to advocate for the USPSTF to modify that recommendation so that the same degree of availability of testing, the same standard. Hey, you know what? PSA testing may or may not be right for you, but you should talk to your doctor about it, and you should discuss it with your family and talk to your doctor and decide whether or not this is something that's appropriate for you. Not only is it appropriate for you, but when is it appropriate for you?
Right, right. We're speaking with Dr. Kapoor, president of Advanced Urology Centers of New York. Father's Day coming up, and let's talk about the symptoms of prostate cancer. I mean, we talk about screening. Can someone simply say, hey, you know what, I think something's not right, or is this something that presents?
That is a great point. That is the most important take-home message for people today, and that is that the most common symptom of prostate cancer is no symptoms at all. The simple fact is that you cannot tell whether or not you're having prostate cancer based on your voiding symptoms. You know, people tend to associate difficulty with urinating, whether it be waking up at night or a change in their stream or urinary frequency. But these are more commonly associated with a condition known as BPH, or benign prostatic hyperplasia. So it's much more common to develop urinary symptoms from conditions other than prostate cancer. And the simple fact is that if you wait until you develop symptoms of your prostate cancer, then the probability that you are going to be able to cure the disease goes down exponentially. So the only way to really find prostate cancer is to proactively look for it. You know, this is a disease that you don't find it unless you look under the rock. You know, you got to look under the rocks to find the disease, because it will grow silently until the point in time where it's just no longer treatable.
Thus the importance of screening. And how often should these screenings be done?
Well, you know, that's another great point. And the majority, the consensus guidelines for when a man should be screened is that a screening regimen should be customized to every human being, right?
Okay.
You're not the same as me, and I'm not the same as the next person, and nobody is the same as anybody else, right?
Right.
So why should we have a one-size-fits-all recommendation regarding prostate cancer screening? What the international consensus guidelines of physicians that care for men with prostate cancer is that a baseline screening be done sometime during a man's 40s, that you get a baseline. And depending on the results of that baseline screening and your risk factors, remember, if you're one of those 3 really high-risk groups, if you are an exposed veteran, a veteran exposed to chemicals like Agent Orange,
Right.
a man with a family history, or somebody of African-American descent, if you're in one of those risk categories, depending on the results, you may need to be screened a little bit sooner than somebody else.
Right.
If the results of that test indicate that you are at very low risk of disease and you don't have any other risk factors, you may be able to safely wait 5 years, maybe until you're 50, to get your next screening done. So once you get that initial baseline test and you're able to have a conversation with your physician regarding, hey, what are my risk factors? What do I have to worry about developing prostate cancer? Then you can create a customized screening regimen just for you. And that customized screening regimen can be used, and of course it can be modified as time goes on, as your health may change or as that other circumstances may be modified. So you get a baseline screening sometime in your 40s. After that, you have a conversation with your physicians where you go over the results of that baseline screening test, and you create a custom regimen.
Okay.
That said, for those men that are in a risk category, a high-risk category, certainly you should have PSA testing done probably on an annual basis starting at age 50. And in addition to those other risk categories, I should mention that we are now, because we've sequenced the human genome and there's all these molecular tests that exist, so we also now know that there are certain genetic predispositions to developing not only prostate cancer, but other cancers. So if somebody in your family has some of these gene mutations, or if you're identified as having some of these gene mutations, then of course that genetic counseling needs to be done as well, because that is another dimension that we are adding to our armamentarium as we go forward to determine who should, because again, we talked about looking under the rocks,
Yeah.
but it's really helpful to know what rock to look under.
Gotcha. Genetics. Yeah, that's a big one. All right, so let's talk about treatment options. Have they improved? Are they reasonable at this time?
Well, we're continuing to evolve our treatment strategies. One of the things that we recognize is that not every man who is newly diagnosed with prostate cancer needs to be immediately treated. Some men do definitely need to be treated right away, but there are other men who can safely defer intervention. And that group of patients is known as active surveillance. So depending on the degree of aggressiveness of your cancer, you can have a conversation with your physician and determine whether or not surveillance is appropriate for you. Now, it's important to understand that surveillance is not the same thing as benign neglect, right? So when we're saying that we're deferring active therapy, that doesn't mean, okay, it's time for you to move to the South Pacific on an island and put your head in the sand. No, that's not what surveillance is.
Right.
What surveillance is, it's a very dedicated program by which we monitor the progression of the disease, and if at any point in time it looks like the disease is starting to progress, we'll jump in with intervention. So there's a big subset of patients for whom active surveillance is a great option, and obviously that's something that is coming more and more prevalent as we start understanding the biology of the disease. Now, you mentioned genetics and how important it is. We now actually have the ability to take a look utilizing genetic and molecular markers into the DNA and into the chromosomes of the cancer cells to determine what the probability is that cancer will become a more aggressive disease. So, for us, this is a truly exciting time in terms of prostate cancer therapy. Not so much because the therapies are changing that rapidly. Candidly, the treatments that we're doing today are pretty much the same as the treatments we were using 5 years ago. We've gotten better at them, and the techniques have gotten better.
Right.
The hospital stays have gotten shorter.
Yeah.
The risks have gotten less. But they're more or less the same surgery and radiation and various combination options that we've got. But what we've gotten much better at is determining which is the right treatment for the right patient. So, So is it appropriate for you to have surgery? Is it appropriate for you to have radiation? Is it appropriate for you possibly to have hormone therapy before one of your other treatment options?
Right.
Well, in the past, before we had these molecular and genetic markers, we were kind of flying a little bit blind. Now, this is a whole new avenue in our armamentarium that enables us to really sit down and counsel a patient as to what the right thing is for them. So what I would say to you is that it's not so much that that we've made enormous breakthroughs in terms of the treatments of prostate cancer, but we have made tremendous strides in targeting those treatments to the right people.
Okay. Well, that's encouraging. And I guess, for all the men listening right now, and they may be grimacing a little bit, the treatments themselves, a lot of the treatments are not that unpleasant from what I understand. They're not terribly invasive. Of course, I'm making some generalizations here, but once you're on target with how you want to go at this, they're not quite as bad as people would imagine.
Well, I mean, certainly cancer therapy is never, it's a very traumatic. We don't want to belittle the fact that being diagnosed with prostate cancer or any cancer.
No walk in the park, for sure.
Absolutely not. It's a very traumatic and it's an extremely emotional experience for not only the patient with any cancer, but their whole family, and it's important for men to realize that they've got a support team. Our foundation has prostate cancer support groups that meet regularly throughout the region that they can go to the foundation website to find. So it's important for men to know that they're not alone. And whether the right treatment option for you is surgery or whether the right treatment option for you is radiation, the important thing is that your long-term complications, regardless of the therapy that you choose, are generally very limited. So the techniques have gotten very, very good. And although there are certain risk factors that are associated with each type of therapy, and you have to be aware of them,
sure,
the point is that most of those things don't last forever, and they're all very finite in nature. So what I tell men is that you give me 6 months and I'll give you back the rest of your life, because the simple fact is the 5-year relative survival rate for localized prostate cancer is 100%. 100%. The 10-year survival rate for all stages combined of prostate cancer is 98%. 98% 10-year survival. But what is the one thing that we must have to be able to get that? Is we've got to find the disease first.
You got to screen.
You got to screen. You got to look for it.
Right.
That isn't true if we don't know you've got the cancer.
Right.
Having a screening does not obligate you to get a biopsy. And if you get a biopsy, it doesn't definitely mean that you're going to have cancer. And if you have cancer, it doesn't mean that you absolutely have to be treated right away.
Right.
All of it is at every point in time, you've got a team of expert physicians, like, for example, at Advanced Urology Centers of New York. As you mentioned, we've got close to 100 physicians in different specialties that work together in a team fashion to manage the patient with prostate cancer. So the newly diagnosed patient has to understand there's a team of people that's going to be behind him to walk him through the process so that at the end of the day, having had prostate cancer is just going to be a memory.
Wow. So get screened, grab your fate, and control it. We've been talking with Dr. Kapoor, president of Advanced Urology Centers of New York, the largest urology group practice in the United States, and we're talking to you guys about getting screened for prostate cancer. Good luck, good health. Thank you for joining us today.
It's been my pleasure. Thank you for giving me the opportunity.
Absolutely. You've been plugged into Long Island on 102.3 WBAB and 106.1 BLI.